Hi, everyone. Welcome to another episode of the GHAPP MASLD MASH Community Network Education Series. Today's topic of presentation is MASLD or Metabolic Dysfunction Associated Steatotic Liver Disease Pharmacotherapy. And again, my name is Jonathan Ye. I'm a PA. I am working for Columbia University Irving Medical Center, Center for Liver Disease now, and I've been doing the liver disease for the past 14 years, and I'm loving every minute of it. Here is a QR code you can use to record your attendance for this meeting as a proof of attendance. Here's another QR code that you can use it to visit the GHAPP MASL MASH Community Network to view Madrigal MASH disease state education and Madrigal Rezdiffra promotional program. Okay, so here's today's presentation. Um, we are starting by introducing the treatment options up to date. We're using this metabolic management. So it's maybe a good time for me to just do a quick introduction to the new nomenclature. We in the liver disease and GI, we know that fatty liver disease have been used for quite some time, quite a few years, at least for 10 years up until about 2, 3 years ago, when the true mechanism or the etiology was found about how fatty liver came about. So the name fatty liver disease or NAFLD, non-alcoholic fatty liver disease, have been changed to metabolic dysfunction associated steatotic liver disease. So it made it very obvious that so how the fatty liver came about is really because of the dysfunction of metabolic process. Now, here on this slide, we can see that in terms of treatment-wise, weight loss is still the mainstay for metabolic dysfunction. To treat the metabolic dysfunction, so MASL and MASH. Lifestyle modification is listed as the top method to for weight loss, and there are the other weight loss medications, traditionally like phentermine. Those who are CNS, they are affecting the CNS, and they usually carries a lot of CNS side effect. That's why it's not widely used and only limited to real experts in weight loss treatments. Then bariatric surgery is another one, and also a good method for weight loss and can at the same time control and help the improvement of muscle. Newer ones, agents for weight loss, like a GLP-1 receptor agonist, such as semaglutide and Tirzepatide is a GLP-1 slash GRPRA. So these are the mechanism of action actually will come up in a few minutes in the upcoming slides. So I'm going to leave it there for the weight loss square. Also, I'm gonna go with the lower right-hand side one, the liver-directed treatment, which is using vitamin E. But if patient has diabetes, vitamin E is not recommended. Pioglitazone is one of the GLP-1s, but it's not as how should I say, the effective. Also, we're gonna touch up on that later. Resmetirom, that's the latest entry to treat the liver, the MASL and MASH, and by working on liver directly, not through weight loss, not through decreased diabetes. Now we go up. to the last square, it says to treat the type 2 diabetes and cardiovascular risk factors, hyperglycemia, hypertension, and dyslipidemia also can help improve the MASLD treatment. Now, we're going to talk a little bit upon the GLP receptor agonist, which is they're really the full name is glucagon mimetics. That's the class. The word, so how they if exert their effects is really by stimulating glucose-dependent insulin secretion. They suppress the glucagon, so the more glucagon will are not secreted into the blood. It delays gastric emptying, and it directly acts on the hypothalamus to promote satiety and reduce energy intake. So by doing all these 4 points, working on these 4 points, medications such as semaglutide and tirzepatide, they basically make the person who's taking it feel full easily, and eat a little bit of food will fill them up, and there's no appetite also. That's one the real world feedback from patients taking GLP-1s. And also, there are the GLP-1 receptor agonists are analogs of the gut-derived incretin hormone, glucagon-like peptide. That's actually type 1. Also, GLP-RAs lower the blood glucose and cause weight loss. Then, what is the GLP-1's role in hepatology practice? So, like semaglutide successfully met both the primary histological endpoint at 72 weeks. Actually, this was published early in 2024 about its effects on metabolic dysfunction associated steatohepatitis, or MASH, and that was published in the New England Journal of Medicine in early 2024. So consider administering GLP-1s for overweight MASLD patients, with a higher priority given to those with MASH already. MASH, to those who needs a little bit of clarification, MASH is the inflammation form of the MASLD, and it's usually will cause how should I say, cause the liver to progress into fibrosis more quickly. Then how do GLP-1s affect GI providers? Meaning, for GI providers do endoscopies, and then how do they accommodate patients on GLP-1s? So we have to pay attention that they have, since the patients on GLP-1s will have delayed gastric emptying, they will have higher or increased risk of aspiration on anesthesia. And if a patient has taken a dose of GLP-1s within 7 days of their scheduled GI procedures, there is increased risk with administering anesthesia, so should consider canceling or rescheduling the procedure. Vitamin E, well, I'm not going to spend too much time. Just remember, it used to be recommended, but then further study shows that it may work, and it definitely does not work with patients having diabetes. What about pioglitazone? That in itself, it is a GLP-1. The only thing is it does not, its effectiveness has been proven not effective by several studies in the past 2 years. So it's really, for at least for my practice and my attendings at Columbia, we don't use, and we actually will avoid the pioglitazone for patient wanting to lose weight. And what about Resmetirom? Again, this is the golden boy in the past 2 years. The rich people handing out thousands, tens of thousands of dollars to fight for. Well, actually, that's not it. It was, sorry, that was for GLP-1s. But for resmetirom, that's still the golden boy, because that's the only one that's currently indicated to treat MASH by FDA. So it was approved in March 2024. It's indicated to treat adult patients with MASH without cirrhosis, and has to be in conjunction with diet and exercise. It works by stimulating the thyroid hormone receptor beta agonist to achieve its goal of improving, while resolving the MASH and also improving the fibrosis stage. And it selectively binds to and activates the thyroid hormone receptor beta receptor in the liver. The physiological relationship between thyroid and liver. So thyroid actually works in the liver by regulating the transportation of fat outside of out of the liver. So with the dysfunction of thyroid hormone beta, there are abnormal accumulation of fat and fatty acid in the liver. Thus, MASLD and MASH come about. Now, resmetirom stimulates the thyroid hormone receptor beta and makes it work harder to transport the abnormally accumulated fatty acid and fat outside of the liver, thus achieving the goal of resolving MASH and also improve the stage of fibrosis. Now, the main registration trial of resmetirom, which is still on the accelerated approval status, is the MAESTRO-NASH, and is an ongoing phase 3 randomized controlled trial of resmetirom in NASH or MASH with a liver fibrosis. The trial included patients with biopsy confirmed F1B, F2, or F3 fibrotic patients. There are about 1,000 patients equally divided into 3 cohorts with a placebo, 80 milligram, and 100 milligram arms. So the 2 co-primary endpoints at the end of week 52 were MASH resolution without actually regression of fibrosis status, and also an improvement in fibrosis stages without worsening of MASH. And on the right, you can see that's the original New England Journal of New England Journal of Medicine published the registration trial that effected the accelerated approval. And then here's the safety data during the phase 3 trial. Diarrhea and nausea were the most common reasons for discontinuation of the study, and there were serious side effects that usually happens with the AST, ALT elevation. But just remember one thing: there's no black box warning, and there's no death. And in terms of the 2 primary endpoints, during the reason we're looking at the let me see if there's no stratified data in this on this presentation. So I'm just going to talk about these 2 original primary endpoint, the achievements. So compared to placebo, the resmetirom 80 milligram and 100 milligram arms achieved of the MASH resolution with no worsening of fibrosis, and achieved fibrosis improvement without worsening of the MASH or MASLD activity score. This based on the the diagram, we can actually see that the improvement over placebo is about 1 to 1.5 times of placebo. What about some practical considerations for managing MASH with resmetirom? Um, the ideal patient for treatment are adults with non-cirrhotic MASH and patients with moderate to advanced liver fibrosis, specifically stage F2 and F3. And it's only approved in conjunction with diet and exercise. Then what about drug-drug interactions? Genfibrozole and cyclosporine are two medications not recommended to be co-administered with resmetirom. And genfibrozole is a very old-fashioned anti-lipid medication, and cyclosporine it's an immunosuppressant usually used on post-transplant patients. Then what about patients on clopidogrel, which is Plavix? Because of the drug-drug interaction, the co-administering with resmetirom will increase the blood concentration of clopidogrel. So when the patient has to be on the resmetirom while on Plavix, the patient needs to be the resmetirom dose should be reduced by 20 milligram to start. So for a person who's supposed to start with 100 milligram, they need to be reduced to 80, and who's supposed to start with 80 milligram, they need to be reduced to 60 milligram to start. Then what about those? There are also medications at risk of increased exposure due to resmetirom, and here are the list of it. Repaglanitide, pioglitazone, these are all the type 2 medications for type 2 diabetes, and lomotrigine for seizure, and montelukast for allergy. And also, when co-administered with anti-lipid with statins, there should be some cap with Pravastatin, Simvastatin, atorvastatin, and rosuvastatin. They should be capped at 40 milligrams for Pravastatin, 20 milligrams for Simvastatin, etc., etc. Then again, more practical considerations for managing MASH with resmetirom. What about the duration of treatment and monitoring? Well, ongoing evaluation of this still going on with the MAESTRO-NASH trial, but likely we need to restage fibrosis with non-invasive testings such as FibroScan or the vibration-controlled transient elastography or proton density fat fraction with the MR. CAP also is a control attenuation parameters. This also produced by FibroScan machine or serum ELF, enhanced liver function study. Then what about the expert panels? They are currently working on cutting points or the cut points or the stop point in order to gauge the effects and to see how long the resmetirom needs to be continued. So with all these are the treatment options that we currently have. There are still questions remain. As widespread resmetirom use will depend on insurance coverage, which is in New York State, has very little problem. But we know that there are other states throughout the country, they are still not covering resmetirom. That poses an obstacle for more patients with metabolic dysfunction associated steatotic steatohepatitis to be treated. And there become an inequality in terms of treatment gaps with the different by geographic areas of United States of America. Then also periodicity of staging and lab tests for monitoring. Um, I think of with the more experienced practitioners, this should not be a problem. As what we do in Colombia, we usually, after patient started on resmetirom, we will do our first liver function study, and at the beginning of month 3, so about 8th or 9th week after the start, we get a blood test. And then after that, we will continue every 3 months blood test to monitor the liver function. And also thyroid function should be checked during a baseline, and then once a year or once every 6 months, even though there's no, these are anecdotal. So far, it works so good, but a continued study is being conducted. And another question is that the patients on resmetirom will need duration of treatment recommendations and when to discontinue treatments. Multiple agent currently in clinical trial and likely will have more options in near future. So that's it for today's presentation. Thank you for your kind attention.